Hello, I'm Zach Meisel, and thank you to SAM and to you for this opportunity to give this plenary session. I'm going to present the Life Storied Study, Stories for Opioid Risk Reduction in the Emergency Department. This was a comparative effectiveness study of two individualized acute pain treatment communication tools. There are no commercial disclosures. This study was funded by PCORI, the Patient-Centered Outcomes Research Institute, and my time is also funded by the CDC and the NIH. I wish to thank an amazing team who helped make this massive study possible. The team included co-investigators, patient investigators, storytellers, filmmaking team, as well as an advisory board members and large study staff. In particular, this study is dedicated to the memory of Paul Yabor. Paul was one of our storytellers who discussed so candidly his experiences with pain treatment as well as substance use disorder in an effort to help people better understand their risks and make more informed decisions. Tragically, Paul died just weeks after sharing his story for the camera as part of our study. Here is Paul's story.
I came down with a condition called peripheral neuropathy that affects the nerves in the hands and the feet. It especially impacted my feet, very hot, burning, painful, like needles in the bottoms of my feet. An opiate-based pain medication, Oxycontin, was suggested to me. And at first it worked very well, but I began to abuse it. I had some experience with casual drug use, marijuana, social drinking, even snorted a couple of lines of cocaine somewhere along the line. My mother was an alcoholic, and my father was also an addict. But I was never prepared for the impact of abusing prescription opiates had on my life and the dark path it led me down. In the beginning, I thought I really had it. It was okay to take a couple of pills, even to crush one up and snort it. No big deal. I could handle this. What I felt at first was euphoria and relief turned into a constant state of paranoia that I'd run out of pills or not have the medication nearby so I could take it when it desired me to take it, because it kind of took on a persona of its own. And it was just an avalanche after that. Things got worse. I would run out of pills and have to search for more and scrounge up money, and eventually led me to heroin abuse. I slowly disintegrated, and I didn't realize it. I didn't realize how sinister the process was, how secretive it was, and I lost myself in a slow manner that I didn't even recognize. So I lost my girlfriend, lost my car, lost my house, lost my license, went to prison, destroyed my relationship with my family, and eventually I acquired HIV.
Paul's story sets up a key challenge to patients and providers. What are the best ways to communicate opioid risks to patients with pain and align their preferences and values while not exposing them to additional risks? The objectives of the study were to compare the effectiveness of two individualized opioid risk communication tools using, one, a visual display of one's opioid risk misuse, and two, a visual display of one's risk of opioid misuse plus a narrative enhancement video like the one you just saw, and three, a generalized risk communication sheet, which is usual care. At a high level, we sought to compare the effectiveness of these tools on patient-centered and reported outcomes for emergency department patients who present with acute back pain or kidney stone pain. This was a multi-centered randomized clinical trial performed at 4 geographically diverse emergency department settings. These were our inclusion criteria and exclusion criteria. This schematic demonstrates our enrollment and data collection protocol. Patients were approached in the emergency department after being evaluated by their treating physician. If they were deemed likely to go home and determined to have back or neck or kidney stone pain, they were then enrolled and randomized to receive one of 3 interventions, which I will describe next. Baseline data were collected as well as follow-up data on days 1 through 6, then 7, then 14, and again on day 90, using a patient-reported outcome web-based data collection tool called Way to Health. The usual care arm received a standard patient information sheet about their condition. We assessed patients' baseline opioid risk using the previously studied opioid risk tool assessment called the Opioid Risk Tool, or the ORT. We then translated that risk into an automated infographic for different risk categories. The infographics leveraged the use of a visual thermometer-like scale and the use of probabilistic communication methods known to be effective in risk communication. It provided basic information about why and how the risks were assessed, as well as some information about options and encouragement to discuss them with a provider. Each participant in the two individualized risk communication intervention arms, as well as the treating provider, were shown their risk assessment. Participants in the narrative enhancement arm were shown the probabilistic risk tool and also provided an opportunity to view short, real stories from study partners who described their experiences with pain and pain treatment, and sometimes substance use disorder. Not all the stories were about addiction per se, but all involved a description of individual risk, pain treatment, and they all had a narrative arc. Participants in this arm were encouraged to watch at least 2 video vignettes in the hospital, and they had the option of watching more at home. Pre-specified outcomes assessed were risk awareness and recall, the presence of opioid medication use at day 14, the preferences for opioids upon discharge, and satisfaction with pain treatment 1 day after the ED visit. 1,302 patients were randomized 1:1:1 across all 3 intervention arms. The day 14 response rate was approximately 70% and was equal across all 3 treatment arms as well. Here are the baseline characteristics. We enrolled about 3 times as many patients with musculoskeletal pain and back pain compared to renal colic. There was good distribution across gender, race, and ethnicity. Randomization worked well, and there were no significant differences by baseline characteristics across the treatment arms. There were no significant differences by treatment arm in each risk category for opioid risk. Approximately 1/5 of all the enrolled patients were ultimately prescribed opioids in the emergency department. And now for the main results. Recall of opioid misuse risk score was assessed only between the probabilistic and the probabilistic plus narrative enhancement intervention arms. 39% of the participants in the probabilistic arm recalled their risk score, and 44% in the probabilistic plus narrative group recalled their risk score at day 14. This difference was not statistically significant. However, we pre-specified that this risk recall effect may be most prevalent among the high and highest risk scoring participants. And indeed, we found a 22% difference between the probabilistic and the narrative arms in terms of recalling their risk in the high and highest risk group. This was statistically significant. Preference for opioids was an additional primary outcome, and here we included the GRC, or usual care arm, in our analysis. 33% of participants who received usual care requested opioids, whereas 28% in the probabilistic and 20% in the narrative arm preferred opioids. These differences were significant even when adjusted for type of condition, as well as opioid risk score and demographic characteristics. Again, here, the narrative enhancement appeared to have the strongest effect in reducing preferences for opioids. By day 14, 11.4% of the participants reported still taking opioids, either from their original ED prescription or a new prescription. Here is the breakdown by treatment arm, with the risk communication arms reporting differences that were not statistically significant. We measured patient satisfaction with pain treatment. This was captured at day 1 after the emergency department visit, and on a scale of 1 to 10, in this analysis, the narrative group reported significantly higher satisfaction at 7.3 compared to the probabilistic only and the usual care participants at 6.6. So here are our key takeaways. For patients who present to the emergency department with acute back, neck, or kidney stone pain, there may be some benefits to assessing and showing patients their own individualized risk score for opioid misuse. These benefits manifest in terms of reduced preference for opioid use, patient satisfaction, and recall of their individualized score 2 weeks later. We did not see any differences in opioid use at day 14, but among the other effects, there do appear to be differences, with the strongest effect being seen among the group that received the narrative or storytelling enhancement. The stories we used were real stories told by patients with complicated and emotional experiences that were shared in a brief online format. There may be future opportunities for these types of interventions for risk communication and shared decision-making scenarios. Please watch and use the stories that our patients shared as part of our study. Thank you so much.